If you have any questions, have them ready. We have some from email, some from the moderators, and we're going to accept some questions also from the audience.
So I'm going to get going on these questions. I don't see any emails yet, but we're waiting for some. And we have about 10 minutes for discussion, so I'm going to start quickly if I can. First of all, to Paul. You up here? Is Cursillo still here?
I think he had to take a flight.
Oh, he had to catch a flight. Okay, you want to come and take the questions? Zarone, you're afraid? Come on. No, okay. We're like a family here, right? This is, all right. So we'll ask anybody. Anybody here doing single port?
Yes.
All right, so I want to know something. Are we better off with a platform for doing this? You know, they make these platforms with multiple holes in them and all these multiple things, some of them more complicated than others, are even using the robot now. Are we better off with the platform, or if this is going to catch on in the future, can we just use those multiple trocars? What do you think? Homero, you want to tell us, or
my own experience is in the earlier days, I think we all experienced that we had more functionality and more flexibility with having separate individual ports instead of a multi-hole platform. The ones being created today, their functionality has improved. And one of the other things that it does is it's allowed us to kind of battle a lot of the issues. Having multiple puncture holes in a fascia was somewhat of a concern and an issue. Also, extraction of a specimen was somewhat of another issue. So most of these have kind of a skin barrier protector, a sleeve to it. So it makes it interesting and very positive, as well as just having one fascial incision.
do you think the robot's going to find a home here in a single site?
The robot's finding a lot of sites, so I think it's going to make its way there also. But I think the mass population's probably not going to adopt the robot. Is my first guess.
All right, I want to ask Silvana a question. I want to understand how the bilateral myotomy lengthens the proximal esophageal remnant or whatever.
Yes.
Can you tell me how?
Well, usually for achalasia at least, you know that different types of myotomy have been tried, starting from the levatidis one, circular or spiral. But the problem with those myotomies is that they cut both the longitudinal and the circular layer. That left only the mucosa. That's why they had complications such as outpouching. If you cut just a circular layer, you get the length, but I hypothesize that you will not get the dilation problem because you still have a muscular.
But in the children who have atresia, it lengthens it by cutting the muscles?
Well, I didn't have any piglet. We are still pig child. No, we are still in the animal model. What we did, we tested different types of myotomy with stretching technique, and what we saw is that the total circular myotomy gives you length, but the esophagus loses strength, and that the bilateral myotomy is capable of elongating the esophagus, keeping a good compliance.
Maybe we need the myotomy with the magnet together, and we'll really have something.
That's what we've done for the anastomosis.
You've done some for the anastomosis,
Yes.
right. Terrific stuff. Okay. Homero, I wanted to ask you, there is a new device for reflux. None of you folks mentioned it. The Scott Melvin talks about it. I forgot what it's called, Lynx or something, where it's magnetic, and you put it around like a band around the lower esophagus at the EG junction, and it grabs to itself like a bracelet. Do you know anything about that?
I have no experience, no exposure to that, but you know, I would just warn everyone that magnets, they're very difficult to control their force, their energy once you use them.
I think I have seen quite a bit on the Lynx. I think that's actually a potential kind of in-between therapy, a little maybe more effective than our current endoluminal therapies, maybe not as much of a barrier for Nissen, but maybe more physiologic. The interesting thing about the Lynx, it's basically a rosary of magnets that are allowed to slide along there, so that when you put this around the lower esophageal sphincter, when you swallow, the bolus pushes the magnets apart. They actually lose some of their attraction force, and it's more physiologic. And they seem to have figured out how to put it in place without erosions and things like that. So I think it's a pretty compelling technology, and I'm going to be interested to see the clinical trials.
I'm excited about seeing it, yeah. Okay, so Brian, as long as you've got the microphone there, I want to tell you that I admit here in this great room that I have used Barretts on patients with non-dysplastic Barrett's esophagus. Is that going to come? Are we going to be able, why not just take every patient with Barrett's and burn them?
Yeah, there's a lot of debate about it right now. I will say that I'm in a camp that believes that if you are already suffering what I believe is a complication of gastroesophageal reflux disease, that we should be aggressive about managing that and not just treat it expectantly, similar to a colon polyp. Having said that, it's not clear whether it's necessary to do this for non-dysplastic Barrett's in some people's minds, and so I'm hesitant in a room like this to say that that's where we got to go, but I think conceptually it makes sense, and you're going to see data coming down the road. It takes a long time to generate that data, but you're going to see data coming down the road supporting that. And I have patients now that feel like this is a ticking time bomb.
Yeah.
And so I will selectively use it in non-dysplastic Barrett's.
Have you seen any buried glands? Has anybody showed buried glands with this technology?
Actually, yeah. Interestingly, New England Journal of Medicine study, and I didn't have time to show all of the work out of that study, had a significant rate of buried glands in both groups. But what was interesting is that the percent of buried glands baseline before anything was done in either group was somewhere around, if I remember right, around 15%. In the placebo group that went up, nothing had been done with their Barrett's. In the treatment group, it had been down. So buried glands, we're starting to understand, is actually a natural state of the Barrett's esophagus. And so maybe that's not quite the damning thing that it used to be when we were evaluating endoluminal therapies. We used to think if you got buried glands, that was a bad therapy. The RF definitely decreases the buried glands and does so more than acid suppression and placebo.
Samuel, I loved your videos. I think that they were just the best. And the question is, you said something that slowed me down a little bit because I usually preach opposite. You said if you suspect preoperative stones, you do pre-op ERCP. We're trying to say around here, and a lot of people send them to me, and I like that they do, but for pre-op ERCP, but there are a lot of negative ERCPs if they just look at liver functions, even ultrasounds. When you say suspected stones preoperatively, what do you mean by that? Or do you send all patients with an elevated ALK phos for ERCP?
We've been working in different places.
Yeah.
So in certain areas we have all the facilities, and in other areas we don't. So what I mean with that if we know ahead of time that there is stones in the common duct, we don't send it to ERCP. I think United States, Europe, most of the developing countries, that's the routine that they do. What we do is we go ahead and explore the common duct directly. If we can, we do it transcystic. If not, we just do choledochotomies, open it by regular laparoscopy. We review this because I'm talking here to some of the world experts in endoscopy. The whole meaning of the meeting is the progress in endoscopy. So we are on the same boat, but we have analyzed and recognized what's happening in many countries. We didn't write a paper because it has a lot of bias, but I reviewed some years back 500 ERCPs from 10 different endoscopists, of course, without their approval. We found that only 68% of them, they were able to clean the biliary tree. 68.
Particularly in your country, because you see big stones.
Yes, so it's a very high numbers. Yesterday, we heard in education, one of the extraordinary meetings here, that an average to be able to have 85% of successful to cannulate and to work the biliary tree, you need 100 cases at least. Many countries in Latin America, an endoscopist does 100 cases in 10 years, They don't do it as everyday routine, So I think we have proved many authors here, Pretelin, Phillips, yourself, we have shown that, it's possible to do exploration of the common bile duct, decrease the cost, same morbidity, even probably less morbidity, and we can achieve that. I think we have to train residents to explore the biliary tree. Of course, there is a lot of space for endoscopy, for left stones, and in some places, of course, if we have all the resources to do it, in common bile duct stones, to do ERCP first, followed by cholecystectomy. But I think we should include, we have seen so many advances, beautiful things, and I don't see why a surgeon cannot explore the common
I want to give one fellow from the audience a chance to say something. Go ahead. We have the floor mic on, and we're going to have to end in a minute. Go ahead.
Dave Mankey from Green Bay, Wisconsin. Once you have a stent in place, how do you decide that the fistula is closed, and do you ever reopen it when you take the stent out?
Can you, we're talking about fistula in the esophagus, biliary tree.
Any place you put a stent in because you have a fistula.
Let's say it's a gastric leak, Jose.
It all depends on what the natural history of it is. So the gastric leaks, biliary leaks, all those have a very common closure rates, and those we expect. Usually in about 2 to 3 weeks they're closed. Most of us end up leaving these stents because we realize that it's not that big of a deal to remove them until about 4 to 6 weeks. The ones that are a real problem, those are the ones that you have to continuously study, are the ones that are chronic fistulas, especially those tracheoesophageal fistulas that have been around forever, have been managed already for a number of months through drainage procedures, clips, glues. Those we tend to leave the stents in for a much longer period of time, and the success rate on those are usually a lot lower too. But it's studying it at the time of the intervention that gets done again. The main things we always do is make sure the stent remained in place and did not migrate, and then once you've accomplished that, is after the stent is removed, restudy the patient. So if it's on an ERCP, we do another intracholangiogram, demonstrates whether there is a leak or not. If it's the GI tract, then we'll get another upper GI study and verify whether the leak is present or not.
We're going to have to end this now, I think, to be fair, and I want to thank everybody for great presentations. Thank you.